This episode of Pupil Pod is supported by Genentech.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board-reviewed topics. I'm your host, Sila Bal, and my guest today is Dr. Avni Finn. Dr. Finn is a vitreoretinal surgeon and Assistant Fellowship Program Director at the Vanderbilt Eye Center. Dr. Finn, thank you for joining me tonight.
Thank you for having me, Sila.
So let's get into the case. This is a case of a 47-year-old man with a history of hypertension and type 2 diabetes who presents with a sudden decrease in vision in the left eye. The best corrected visual acuity is 20/20 in the right eye and 20/100 in the left eye. On dilated examination, the patient is noted to have dilated and tortuous retinal vasculature and intraretinal hemorrhages in the infratemporal hemisphere. You suspect that the patient is presenting with a BRVO. Dr. Finn, how would you approach this relatively young patient with a suspected branch retinal vein occlusion?
So that's a great question. I think one of the first things that's important to identify is what systemic risk factors does this patient have for retinal vein occlusion? Typically we want to ask a history that elicits cardiovascular risk factors like hypertension, atherosclerosis, and then glaucoma can also be a risk factor. And glaucoma specifically can increase the risk of BRVO by about 2.5 and CRVO by about 5. Other risk factors that we want to ask about are, do they have a smoking history, any history of hypercoagulability, so like a history of blood clots or family history of blood clots. And then diabetes is controversial but may be associated with a branch retinal vein occlusion. One of the other things that's important for me is, of course, the patient's age. So if they're older than 50 years old, they likely have some of these cardiovascular risk factors. And at that point, I would refer them back to their primary care doctor to optimize their blood pressure, their lipids, and also potentially their blood glucose as well. But if they're younger, like this patient, and don't have any risk factors, I do want to dig a little bit more about a family history of clotting, personal history of clotting, or other medications that could make them hypercoagulable. And I usually consider a workup for acquired or inborn causes of hypercoagulability. And for me, that can include antithrombin, protein CNS, factor V Leiden, hyperhomocystinemia, and then factors 8, 9, and 11. So I will do that sort of workup for my younger patients. The other things I want to do for this patient are, in addition to my clinical exam, I usually get some imaging. And so for a typical RVO patient, I find that an OCT is helpful. This helps you evaluate for the presence of macular edema. And then FA is also very helpful. So in atypical cases or young patients, this can help you rule out other potential etiologies that may be concurrent, like a vasculitis or a uveitis. And then in all patients, it helps you assess for the degree of ischemia. And that's really important to assess for later on down the road neovascular complications.
So before we get a little bit more into the nitty-gritty on the clinical aspect of things, can you kind of guide us through the pathophysiology of a BRVO and what you would kind of expect to see in relation to that pathophysiology?
So, typically what we see on examination is dilation and tortuosity of the retinal veins and associated retinal hemorrhages, and that's usually sufficient for diagnosis in acute cases. We know that the obstruction here is generally occurring at an arteriovenous crossing, and that's really thought to be because those arterioles have these thicker walls, especially thicker if they have cardiovascular risk factors like atherosclerosis or hypertension. That sort of clamps down at that AV crossing and causes basically a backup of blood flow or hemostasis in that area, leading to a vein occlusion. If you're not seeing this occurring at an area of an AV crossing, then you want to think about some of the more atypical causes of a vein occlusion, like a vasculitis or a uveitis that could also present with something similar to a retinal vein occlusion. It's also important to know that branch retinal vein occlusions most commonly occur supratemporally. So if you're seeing something outside of that, you may think about other atypical causes. But those are pretty much the things that we want to look for on our exam.
Okay, so we know that the supratemporal location is most common. Where would you kind of expect to see late neovascularization in a patient with a history of BRVO?
I think one thing that's important to recognize is who's at risk for neovascularization first. BRVOs are unlikely to develop neovascularization unless they have a significant degree of ischemia. And then CRVOs that are ischemic are, at much higher risk for neovascularization. And when we think about ischemia, it's the amount of non-perfusion that we'll see on an FA. So for CRVOs, that's classically defined as 10 disc diameters. But if you see a BRVO with a lot of ischemia, that patient is also high risk. And so I just put my antennas up when I get that first FA and see a lot of ischemia, because I know that that's a patient that's going to be at higher risk for neovascularization. And then getting to your question about where we see that neovascularization. So it's usually at the border of the perfused and non-perfused retina. So at the border of the healthy and ischemic retina. Very rarely, or only really in kind of later, more severe stages, do we see neovascularization of the disc, and then later of the anterior segment. So first you would sort of see it at that perfused, non-perfused border.
Do you ever expect to see visual recovery in those patients? And how much visual recovery could you expect?
Yeah, so in BRVOs, the visual prognosis is actually quite good. And there are a few things that affect their visual prognosis, which I think we'll discuss in later detail in a little bit. But over half of eyes with a BRVO will return to 20/40 vision or better. So that's important to know. There are other things that you can see on exam in terms of return of blood flow. So these patients will get collateral blood flow. And what that really means is that the existing capillaries will start contributing to the venous drainage system. And so you'll get some kind of dilation of those existing capillaries. And so and this is, what we see on exam is optociliary shunt vessels. And what those are is that it's a compensatory mechanism of the eye to help that venous drainage that's been blocked by the vein occlusion itself.
So you kind of already started discussing some of these in the previous discussion questions, but what are some of the other findings you would expect to see in chronic untreated RVOs?
Yeah, that's a great question. And, we don't not treat RVOs very often now, so we don't see this, but we will see things like telangiectasias, as there are vessels that compensate. Sometimes you'll see microaneurysms. A lot of these patients that are untreated have chronic macular edema. And some of the things that you'll see with this is this chronic appearing cystic intraretinal fluid. They may develop exudates on their exam or hyperreflectivities on the OCT that you can see. And then over time, this leads to outer retinal loss on the OCT. There's also a finding called disorganization of the retinal inner layers, where you won't really be able to see the laminations of the retina very clearly on the OCT, and that can happen with chronic untreated RVOs as well.
Now that we have all of this information about BRVOs, can we kind of compare that to central retinal vein occlusions? And can you help myself and our audience better understand the differences in risk factors for a BRVO versus CRVO? So, for example, high BMI and hypertension versus kind of diabetes. I remember studying for OCAP and the boards, and I was always trying to think of clever ways to remember which is associated with which. So, can you kind of give us a breakdown of that?
Classically, what you want to remember is that diabetes is thought of as a risk factor for central vein occlusions rather than for branch retinal vein occlusions. But the other risk factors I think of as risk factors for both central and branch retinal vein occlusions: hypertension, atherosclerosis, and glaucoma. And those are all risk factors that I'll ask any of these patients about.
And can you tell us a little bit about what you would expect to see in a CRVO? I know that we went through BRVOs in detail, but for example, what would you expect to find on clinical exam, on imaging, and how does the pathophysiology differ from that of a BRVO?
So the biggest difference is where the venule is affected in a CRVO versus a BRVO. That blockage or vein occlusion is happening more centrally in a central retinal vein occlusion, but the pathophysiology is really the same, occurring at an area of, where you're getting hemostasis, compression of a venule, that then those risk factors lead to an occlusion. With a branch retinal vein occlusion, again, you're kind of seeing it further on down the road, where you have a branching venule at an AV crossing. And I think the most important thing to distinguish between a CRVO and BRVO is the level of ischemia. So CRVOs are at much higher risk for having a larger amount of ischemia, and that puts patients at much higher risk of neovascularization, either neovascularization in the retina or neovascular glaucoma. And we classically think of non-ischemic versus ischemic CRVOs, and that's an important thing to define. That can be based on some clinical criteria. So your CRVOs that have worse vision, so worse vision than 2200, they present with an APD, those are classically going to be ischemic CRVOs. And on the FA, you'll see a large amount of non-perfusion. 10 disc diameters or more is classically considered an ischemic CRVO. Those patients, again, are going to have much worse prognosis than a non-ischemic CRVO that has better vision on presentation, no APD, and more perfused retina.
Thank you. That is a lot of information about RVOs. And now that we have this solid foundation, can you tell us a little bit about how you would treat this patient and kind of how that treatment might differ than a patient presenting, for example, with a CRVO?
Sure. So, to back up in terms of like treatment options for both branch retinal vein occlusions and CRVOs, we have to kind of go back to, we've gone through lots of different treatment options for these patients, starting with like scary things like optic nerve sheath fenestrations and different things we did during vitrectomy. And then we went through a period of doing, macular laser grid photocoagulation for these patients. And now anti-VEGFs are really our mainstay of treatment. So backing up to grid laser, in the branch vein occlusion study, grid laser was found to be beneficial and was once considered the standard of care for BRVOs. But in the central vein occlusion study, grid laser was not found to be beneficial for macular edema and so was never considered a standard of care option for central retinal vein occlusions. So when we started to have treatment options like anti-VEGF agents for BRVOs, we compared them to grid laser because that was our standard of care treatment for branch retinal vein occlusions. And since that time, anti-VEGFs have really revolutionized how we treat retinal vein occlusions and are our mainstay of treatment. And so any patient with a vein occlusion that has macular edema is usually started on an anti-VEGF treatment option. And those right now include bevacizumab, ranibizumab, aflibercept, and then we have two newer options, faricimab, and coming onto the market soon will be high dose aflibercept. So those are really given to a patient who has macular edema. We follow their OCT for response and then tailor the treatment to that patient. The other option for treating a patient with macular edema is steroids. Both triamcinolone and dexamethasone implants are used. These are usually second line treatment options to anti-VEGF agents because they can cause IOP rises in some of these patients who already have baseline glaucoma, and also can cause cataract if the patient is phakic. So anti-VEGFs remain the mainstay of treatment now, with steroids being second line.
So let's say that this patient was found to have macular edema on OCT. What would be the acute and long-term visual prognosis of this patient? How would you kind of counsel the patient about what you would like to treat them with and what they can look forward to in the future?
So I think there are a few things that contribute to how well a patient with an RVO does. The most important thing is actually age. So older patients do fare worse in terms of their visual prognosis than younger patients. We think it's because maybe their photoreceptors don't recover as well as younger patients. So age is an important factor to consider. We talked about their ischemic status. So how ischemic either the CRVO or BRVO, if there's macular ischemia, are really is a factor that I take into account, and that initial FA will help determine that, as well as their initial vision at presentation. And then, of course, the type of RVO, so CRVO versus BRVO. BRVOs, like the one of our 47-year-old patient, has a much better prognosis than a CRVO. Almost half of patients with a BRVO will get vision 20/40 or better. And then patients with a non-ischemic CRVO, again, having better vision on presentation, no APD, and less ischemia on their FA, are going to return to baseline or near. About half of those will return to near their baseline vision. So for our particular patient, I would tell him that his prognosis is pretty good. The other thing that I think is really important is early treatment for their macular edema. So the shorter duration that CME is sitting there, the better the patient's visual outcome. So prompt treatment is very important in these patients, especially for the BRVO patients that have a good visual prognosis. So I will, if I see macular edema on their OCT at presentation, I will start treating them with an anti-VEGF agent. I usually treat them monthly until their macular edema is gone, and then lengthen the time between their follow-ups and required injections. But overall, I tell them that with treatment and with follow-up, they usually have a good visual prognosis.
So, just as a summary of everything that we've gone through with retinal vein occlusions, and Dr. Finn, please interrupt me if you think that I'm missing something here. In patients with branch retinal vein occlusions, they actually have a really good prognosis, and up to 50% will recover 20/40 or better vision. Of course, younger age is better for those patients. For those of us reviewing for boards and just to know the risk factors for our patients, BRVOs are associated with hypertension, as are CRVOs, but CRVOs are the ones that have been shown to be associated with diabetes. And I now, as you were talking through all of this, remembered my mnemonic, and it was ABCD. So CRVO, diabetes, CD. So for our listeners, if that helps you remember that diabetes is associated with CRVOs. And then for treatment, it's always better to try to treat these patients early. While there are some historic treatment options, today we primarily focus on anti-VEGF treatment for macular edema. Dr. Finn, anything that you'd like to summarize that I might have missed?
No, you did a great job. I like your mnemonic as well. I feel like that's how we survive these testing moments.
Sometimes I look at my mnemonics and even I don't understand what I was trying to say to myself as a memory tool, but it really has been a lifesaver for me. Dr. Finn, thank you so much. Before we end the episode, I ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
I kind of agonized over this question, but I decided to settle on Elizabeth Blackwell. She was the first female doctor in the United States. And as a female retina specialist, I think there are times that you feel alone in your field. And I think it would be really awesome to sit down with her and hear how she felt. She probably had way more uphill battles than we have now because I've been fortunate to have so many male and female mentors that have helped me get here. And thinking back to when she, first tried to apply for medical school, let alone residency, and getting her own practice started, it just must have been like so incredibly tough. So
No, that's such a powerful answer. I think about this a lot too. And I think it was just National Women's Physician Day, like last week sometime. So there was a lot coming out about Elizabeth Blackwell. And one of the things I read actually said that she was accepted to medical school as a joke. And to see her have conquered that like seemingly insurmountable obstacle of everyone thinking she's a joke and not taking her seriously, and paving the way for women like us that now get to stand here, and hopefully we can continue to pave the way for women after us. So thank you for that answer. Definitely timely.
thank you for having me on this podcast.
Thank you. And thank you to those tuning in. See you next time on the Pupil Pod.